So hello and welcome to a new surgical discussions podcast on surgical fluids. My name's Ed
And my name's Johnny.
and we're pleased to be back.
Very pleased.
Very pleased. Yeah, we recorded, I'm sure as you know, a whole series of these podcasts last year covering nearly everything. You say, Johnny?
Yep, just a couple that need to be redone.
But we decided to redo a lot of them because as we've matured, or well, some of us have matured. You especially.
Thank you very much.
Yeah. We thought what we'd do is re-record some of them with a bit of hindsight and hopefully a little more wisdom. Yeah. So should we get started?
Yeah.
Okay. So in this first podcast, we're going to talk briefly about, or I'm going to talk briefly about basic fluid balance. I'm going to talk about some of the concepts that are important to understand for fluid balance and the distribution of fluids. And then finally, I'm going to talk a little bit about considerations of fluid and electrolytes in the standard surgical patient, and indeed any patient. And then
I'm going to have a little chat about assessing fluid balance and recognising the dry patient.
Yeah. And then finally, we're going to talk about some common replacement regimes. One of the questions that I get asked a lot, I don't know if you get this, is, what fluids to use in what situations and stuff like that. And I think it's quite a difficult topic. And it seems that everyone kind of has their own way of doing it. And often in between different doctors, you'll find totally different ways of managing patients.
Especially between surgery and medicine, I find.
Yeah, exactly. So the most important thing is really to try and get to grips with some of the principles. Because if you follow the principles, at the end of the day, you should be doing roughly the right thing. Yeah. Okay. So let's get started by talking about fluid balance and electrolyte distribution. We're going to go back and talk about our standard 70 kilogram man, who's roughly 60 to 70% water. It's roughly 42 litres. And this water can be divided broadly into intracellular and extracellular. Intracellular, found in the cells, is around 2/3 of the water, and extracellular comprises about 1/3. So you can further divide the fluid compartments as shown here in this diagram, and you should be able to see this if you're a video podcast viewer. The intracellular fluid is all its own compartment, but the extracellular fluid can importantly be subdivided into plasma, so the contents of water in the blood, interstitial fluid, so that's the fluid that surrounds the cells, and then finally this kind of weird small group.
And cellular? Yeah. That's things like the pleural fluid, isn't it?
Yeah, and ocular fluid as well. So we talked about fluid compartments, basically which one's which, but what determines the distribution of fluid between the different compartments? Now, we really kind of glossed over this quite briefly, I think, in the last series of podcasts that we did. But so what I thought I'd do is talk a little bit more about the two important forces, and these are the osmotic forces and Starling's forces. The osmotic forces and the concept of osmolality determine the basic balance between the intracellular compartment and the extracellular compartment, while the Starling's forces are important in the distribution between plasma and interstitial fluid, which are, as I just said, two of the most important components of the extracellular fluid. So let's start by going back to some really, really basic physiology. So that's Starling's forces. So basically there are three important Starling's forces, and there's a complex equation that determines the distribution of fluid between the tissue and the blood in the capillary beds. But the important principles are that as blood enters at the arteriolar end of a capillary bed, it's at increased pressure, and this tends to push fluid out of the vessels into the tissue. So there tends to be a net fluid loss. As we move more towards the end of the capillary beds and the draining venules, the pressure is a lot less, and the oncotic pressure of the blood then results in reabsorption of fluid from the tissues. So at the arteriolar end, you get fluid loss driven by increased pressure, while at the venule end, you get reabsorption driven by reduced pressure and the oncotic pressure of the plasma. And permeability, while usually constant, can be changed in disease. If we move on now to talk about the osmotic forces, the key concept here is the concept of osmolality. And this is basically the total number of solute particles in the solvent. The important value to remember is between 280 and 295. And as we said, osmotic forces are important for determining the distribution between intracellular and extracellular compartments, and the osmolality should be equal between these. So what exact solutes are there, and how do we calculate osmolality? Basically, we take all the charged molecules and all the uncharged molecules. The most important charged ones are sodium, potassium, chloride, and bicarbonate, and the most important uncharged ones are urea and glucose. Conveniently, as the number of anions, i.e. sodium and potassium, has to equal the number of cations, i.e. chloride and bicarbonate, we can have a final equation of twice the sodium plus the potassium plus the urea plus the glucose. And that's the important equation for osmolality. Daily fluid balance. Let's talk very briefly about this. There are some important principles that you should take away. Obviously, patients in hospital are often have or are on fluid balance chart where their ins and outs are monitored quite carefully, and this table should prompt you or should make you think about this in your patients. So in terms of important inputs, you've got oral water input, accounting for about 1.5 litres. But you've also got a very important component of your daily fluid input that comes from food, and this is about 1 litre. And then finally, you've got this kind of semi-mystical 0.5 litres of oxidative water, which isn't obvious if you were just thinking about ins and outs. In terms of output, this tends to vary hugely, with about 1.5 litres in the urine, half a litre in the stool. But most importantly, you must remember that there's an insensible loss that occurs through the skin and the lungs. And Johnny's going to talk a little bit later about how this becomes important in disease. So in terms of actual requirements, these are some important equations and figures that I think it would be reasonable to try and memorize. For water, the requirement is estimated at around 40 mils per kilogram per day. And for the electrolytes, so that's sodium and potassium, remember that sodium is the most important extracellular electrolyte and potassium the most important intracellular electrolyte. The most important sodium value, or the requirement per day, is 100 millimoles, and potassium is 60 millimoles. Okay, so that's really my bit done. I think I'm going to talk a little bit about how you assess volume status now, aren't you, Johnny?
Yeah. Yes, I am. So I found in the last couple of months that this is a large part of being a junior doctor, assessing the volume status of your patients, especially if they're septic or something like that. So I think the first thing to do when you're assessing the volume status is to obviously review the notes, look in the OBS chart, check the blood pressure, things like that. Then you need to go and see the patient. So you need to examine them for signs of their temperature, whether they're septic, and therefore maybe they have a fever and the insensible losses have increased. Check the capillary refill and skin turgor. There are other signs which may occur a bit later, such as tachycardia or the blood pressure dropping. There's also the JVP. And then also you can look at softer signs such as the eyes and the mucous membranes. And finally, you can do investigations to quantify. So hypovolemia can be categorized broadly into a number of stages. Stage 1 is with a mild hypovolemia, and generally this is compensated by the systemic vascular resistance, and the blood pressure is normal. With increased fluid loss, say 15 to 30%, stage 2, this is partially compensated by the vascular resistance. And so the patient may have a mild tachycardia, a small postural drop, and a narrow pulse pressure. They may also appear sweaty and possibly anxious at this stage.
And the thing with the postural drop is you don't actually have to get the patient to stand up and then lie down and measure blood pressures at either side. Traditionally, when you're measuring postural blood pressure, that's what you do. But quite a useful thing to do is actually just measure the blood pressure of the patient sat up at 90 degrees in bed, and then measure it lying down. And if there's a significant drop, say greater than 15 or 20 systolic between those two, then you might consider that they would have a postural drop.
So with increased fluid loss, there's later signs, such as a very low systolic blood pressure below 100, a greater tachycardia, they may start to have a tachypnea, and they may become confused or anxious. And then finally, with great fluid loss, they have a very low blood pressure, they may become bradycardic. So another way to assess the fluid balance of a patient is with the urine output. Obviously, as a patient becomes drier, then the urine output decreases. And the most important value to remember in this, I feel, is that a normal person of 70 kilograms should be passing greater than 30 milliliters of urine per hour. So areas where fluid can be lost are obvious areas such as with hemorrhage, vomiting, diarrhea, or indeed with diuresis. Other areas which are maybe not quite as obvious are the insensible losses that we've already mentioned, such as with a tachypnea, or indeed in sepsis with a pyrexia and sweating through the skin, as Ed mentioned earlier. There's also third space losses, such as in pancreatitis or in bowel obstruction. There are a number of additional podcasts which Ed has done, which overlap somewhat with this topic. These are the Acute Renal Failure podcast and the Medical Emergencies podcast, which covers shock.
Yeah, and that goes a lot more in detail into some of the physiology, some of the important causes of shock. Finally, we're going to get to the good bit, basically, which is intravenous fluids. So why do we give fluids? From a very basic perspective, you can think about giving fluids in kind of two situations. These are to resuscitate the patient. So if the patient had one of those things that Johnny was talking about already, so vomiting, diarrhea, diuresis, blood loss, insensible losses, that kind of thing, and they were already depleted, you'd obviously want to get their fluid level back to normal. So this is what we term fluid resuscitation. However, some patients who have inadequate input of fluid, such as say a patient who's nil by mouth awaiting surgery, or perhaps a patient with pancreatitis who may also be nil by mouth, you need to give them maintenance fluids. You need to account for that important amount of fluid that they would otherwise take in terms of water and food during the day. And finally, there's a small subcategory of electrolytic disorders where you would give fluids. That's a little bit beyond the scope of this podcast and more medical, so we'll leave that for now. So basically, there are two types of fluid. There's crystalloids and there's colloids. So crystalloid can basically be defined as water with electrolytes in it, and this forms a solution that's able to pass through a semi-permeable membrane. Colloid, on the other hand, is fluid that contains very high molecular weight molecules that is unable or passes slowly through a semi-permeable membrane. There are a number of important examples of crystalloids and colloids that you should be familiar with, and you should certainly try and learn some of the contents of each of these, as this has particular relevance when compared to, say, the daily requirements of an individual or patient. So the important crystalloids that you would have seen used on the wards particularly are normal saline, 5% dextrose, and Hartmann's solution. There's also a kind of blend of normal saline and 5% dextrose called dextrose saline. However, this really isn't very commonly used.
I haven't seen it used at all.
No, I haven't actually either. So normal saline, the important thing to know here is that it contains 154 millimoles of sodium. So you'll note that actually one bag of normal saline has 54 millimoles more than is required by a patient per day if they were in good health. 5% dextrose doesn't contain any sodium, but contains 50 grams of dextrose in 1 litre. Finally, Hartmann's, which is used certainly a lot in surgery, and I've seen it used more. It's one of these examples of something that's used more in one specialty than another. Is meant to be a very physiological solution, and it contains a whole bunch of anions, cations, but importantly also calcium and lactate. Often they say that one of the complications of giving Hartmann's is lactic acidosis, but I really do think it's quite rare. And certainly I've seen bags and bags and bags of Hartmann's given.
That's more as an exam question.
Yeah, exactly. Just make note of that. Finally, or not finally, but secondly, there's colloids, which can be divided into natural or synthetic. The most natural colloid of all, of course, is blood. But another example would be, say, human albumin solution that's used often in patients, say, with low albumin, so chronic liver disease patients would be a good example. And the other type of colloid is a synthetic colloid, and you'll often see these used. These are things like gelafusin and Hemocil. Okay, so finally, let's talk a little bit about some of the ways in which you use these fluids in the situations of resuscitation and maintenance. As I've already mentioned, I'm not going to talk about electrolytic disorders at all. So very importantly, maintenance is quite logical now. If you remember that you require roughly 3 litres per day, you require 100 millimoles of sodium and around 60 of potassium. So the standard maintenance regime for a patient who's nil by mouth would be 1 litre of normal saline and 2 litres of 5% dextrose. Alternatively, you could use 3 litres of dextrose saline. And that standard normal saline 5% dextrose, or 1 salt and 2 sweet, is often abbreviated to. It's the kind of common denominator of kind of surgical management, I guess. In terms of resuscitation, it's a little bit more complicated. In the situation where you think a patient might be hypovolemic, so perhaps they're septic, tachycardic, maybe the blood pressure is a little bit low, they're going to need resuscitation. And of course, they have a deficit which you need to fill. Now, the way that you usually do this is by giving what we call a fluid challenge. So this is a volume of fluid which you give quite quickly, and then after you've given it, you measure any physiological response. So say a decrease in pulse, an increase in blood pressure, a reduction in respiratory distress. All these things going down would point towards hypovolemia and point towards the patient being dry. So most commonly, what you'll see being done in the hospital setting is patients who are thought to be hypovolemic are given 250 mils of colloid. Now, the rationale for this is that if you give a colloid, it's going to stay longer in the intravascular space and expand the intravascular space. This is then followed once the patient has been adequately resuscitated, so once their observations have been returned to normal. This is then followed by further saline and other maintenance fluids. Okay, I think that's a fair enough summary.
Yeah, I think that's very good.
I forgot to mention potassium, however. Potassium, if you remember, you require 60 millimoles usually per day, and potassium is not actually contained in a standard bag of normal saline or 5% dextrose, so it needs to be added. And say for a standard 3 litre regime, your 1 salt and 2 sweet, you need to add 20 millimoles to each bag. However, there are a few additional points that are important, or a few additional rules of thumb that it's important to know about. The first of these is in the setting of fever. As Johnny already said, patients with a pyrexia require increased fluid input because they have increased insensible output. And this is usually through providing roughly 20% extra per day. Another commonly said rule is that in the post-operative period, you should try and hold off giving patients additional potassium. And the reason for this is in the setting of cellular trauma that occurs in surgery, because potassium is a very important intracellular cation, there's lots of leak of potassium from the cells into the bloodstream. You don't want to additionally supplement this. And then finally, and perhaps most importantly, you must remember that in a standard maintenance regime for an ill patient, you need to replace any additional losses. So they might have that 3 litre requirement that we talked about, but there might be additional litres of requirement because they're vomiting, because they have diarrhea, perhaps they've had giving large volumes of NG aspirate, say in pancreatitis, or perhaps they have a high volume ileostomy output. So all of these things must be collected together. All the information must be collected, and the patient should have replacement of both.
So, in summary, we've covered basic fluid balance. Ed spoke a little bit about osmolality and the forces involved. We covered the fluid and electrolyte requirements, the 100 millimoles of sodium and the 60 millimoles of potassium needed, and the 3 litres of fluid a day. I mentioned a little bit about the assessment and management of hypovolemia in the dry patient, and then Ed spoke briefly about the common replacement regimes and a few caveats to remember when considering poorly patients.
So that's just about it for this podcast. We're going to do these podcasts, I think, a little bit differently to the ones we did before. We're going to kind of jump around a bit and try and re-record the more important surgical topics rather than create a kind of definitive library of everything that needs to be recorded. So we'll see you soon. It's goodbye from Ed.
And goodbye from Johnny.
Bye.
Thank you.